Well, thank you, Jill, and hello to Region 2. I am really glad to be here. Needless to say, I miss being with you all of you in person, but hang in there. We'll all be back together soon. Now, soon, of course, is relative. We don't know when that's going to be, but you know that the whole environment isn't permanent, and this is the next best thing. So thank you for having me. In our time together today, I want to talk about, guess what? COVID-19 pandemic, both of what we've learned and our challenges going forward. Now to begin, maybe with a little bit of financial analysis humor, I thought I would share the newest holiday gift coffee mug that is designed with finance professionals in mind. If you can read it, some of you are familiar with EBITDA, is earnings before interest, taxes, depreciation, amortization, and now coronavirus. And believe it or not, you can actually find and purchase these mugs online. So now, not to make light of a serious situation, but gosh, if you can't find a little humor in almost everything that's going on, then life becomes a real burden. And I know 2020 has been a tough year, no doubt about it. And everyone realizes there's no magic switch that's going to flip on January 1. And, and no one has experienced the intensity of the pandemic than this region, your region, and specifically Metro New York. And you all know that, and we all know that. And so, again, not to make light of a serious situation, but it's been a tough year. Now, for providers, the pandemic has had such a negative impact on a variety of areas: expenses, revenue, payer mix, service volumes, your workforce, liquidity, and that's not even a comprehensive list. I could keep going on. Then you factor in that crystal clear picture of the relief money, where we're still wondering how it will work, how much providers can keep, what the calculations are. There's systems that perhaps some of you that have closed out your June 30 audits only to find that the rules that would dictate revenue recognition appear to be changing. Talk about a complex situation getting more complex, at least from a financial reporting perspective. Now we're seeing some providers are recovering, and certainly much more so than what we thought perhaps back in April, May, or June. But there's no turning back on the uncertainty. That part is for sure. And it's not over yet. Another word that has recently been added to the coronavirus vocabulary is the word twindemic, which is defined as a second wave of the COVID-19 happening during the flu season. Now, we all hope that that won't become a household word, but the reality is that we have a big country geographically, politically, culturally, and that all plays into the virus. So to say that there is or will be a second wave and have that tied to the flu season is real, but it's also perhaps a bit too simplistic. We're looking at multiple waves geographically dispersed, is what I think is the reality. But the forecast for the coming months is not all gloom and doom. The reality is that we know a lot more about dealing with a once-in-a-lifetime pandemic now, in October anyway, than we did back in March. Our physicians and other clinical colleagues have protocols now that they didn't have back in the late winter, early spring. There are no breakthrough therapeutics yet, but even that's unclear with messaging from the current administration as well as the CDC. It's unclear, but there's hope. And of course, everyone's waiting for a vaccine. Now, just a word on the vaccine. The vaccine is not just going to magically make all this go away. There's a lot of what's going on that will have a lingering impact or wake, so to speak. But it does look better. This environment does look better than it did a few months ago. And though we may not realize it, so do we as financial leaders have a clearer picture. We've learned through this lived experience and through experience shared with others. And for you active HFMA members on our website and in our community groups, much of that sharing has come through those community groups, which are groups available to everyone. If you haven't done so, you should check out our community groups, a way to connect with your colleagues of like mind across the country, sharing ideas and helping each other out. The way we've always done with HFMA, but this could be done digitally through our website. So I'd like to spend a few minutes talking about what finance leaders have learned about navigating through this pandemic so far and how it can make the road ahead perhaps a little easier. So remember when shelter in place began, everyone had to ramp up IT capabilities and start working from home literally overnight. I mean, literally sometimes overnight. And the way we reacted was amazing. Back in June, a member of our advisory council shared with the group that he was surprised at what his organization could accomplish virtually because they were so focused. He said things that would have taken 6 to 12 months to implement from an IT standpoint before the pandemic got done in just 14 days. And telehealth is the poster child. And while not to simplify the situation, I recall talking about telehealth in my days as a CFO at Spectrum Health 10 years ago. 10 years. And it still hadn't really had much of an impact on our industry until just a few months ago. For those of you that work in the revenue cycle, if your experience is like others I've talked to, you know that the revenue cycle staff can work from home and be happier and more productive. Working from home is not just for coders anymore. And while the adrenaline rush of the early days of the pandemic is long gone, our challenge now is that while that sense of urgency is, our challenge now is that sense of urgency is not sustainable, but the change process and the focus of new ways of doing things is a good thing. Brainstorming with colleagues to identify success factors, going beyond adrenaline, help overcome challenges quickly. In short, what it means is maybe that our change management process or our change cycles can be much quicker than perhaps they used to be. So what kind of challenges have we overcome? Well, billing and coding for a new disease that was treated in new care settings for one. And that took collaboration with health plans. It's not like COVID-19 was included in ICD-10. And the nature of the pandemic with surges that sometimes exceeded area hospital capacity meant that COVID patients were cared for in settings that had never really seen acute care before. In some cases, settings that had never seen healthcare before at all, like college dorms or convention centers or even parking lots. The document you see in the slide is guidance for COVID-19 coding and billing that came about when one of our policy directors at HFMA collaborated with his counterpart at AHIP. And together they developed guidance for billing and coding in a wide range of scenarios, both inpatient and outpatient. And I'm sure that many of you and your teams have worked closely with your in-network health plans throughout the past months as everyone tried to figure out some of these issues together. And I'm hopeful that these hopefully better working relationships were strengthened in the process and can play itself out in the future. If someone had told me in January that 3/4 of our consumers would be interested in using telehealth, to go back to telehealth, by May, I would have been skeptical. Again, primarily because we've been talking about telehealth for many, many years. Before then, only 11% of consumers had used telehealth in the last year, according to a McKinsey survey. I also would have been skeptical that providers could, again, pivot that quickly. Would physicians buy in? Would the technical capabilities support it? And from a finance standpoint, payment was, of course, an obstacle. And that all changed, and it all changed quickly. As you can see on the slide, in September, MedPAC Commissioner Susan Thompson told the virtual MedPAC meeting that MedPAC should embrace healthcare, or should embrace telehealth going forward. And in principle, there's broad agreement to that. Now, in saying that, there are concerns that payment parity, reimbursing telehealth at the same rate as an inpatient visit, may not be extended past the COVID-19 public health emergency stage. Meanwhile, major payers like Anthem and United Health Group are already reinstating cost sharing for virtual visits that were unrelated to COVID-19. And so that means that that pendulum that swung way far one way is going to swing back a little bit, but not all the way. Pandora's box is open and the genie's out of the bottle, whatever metaphor you want to use. You can't put the toothpaste back in the tube. But the shift has happened. That's the point. And we don't know exactly what the scope of that shift will be. Where will that pendulum land when it goes back and forth? But it's not going to be back to where we were in the pre-pandemic stage. The takeaway message today is that we now know that telehealth is doable at scale. It's happening. Some patients like it. Revenue cycle staff roles are shifting to support that model. And finance leaders were a key part of the team that made all that happen. So with regard to non-virtual healthcare encounters during the pandemic, it turns out that waiting rooms are not an unavoidable part of the healthcare experience. Pre-pandemic, nobody liked waiting rooms, except maybe people that enjoy reading old Reader Digest. But once the pandemic hit, waiting rooms had to be avoided like the plague. And in response, many hospitals and health systems enabled online check-in and registration by phone, and in some cases for patients who remained in their cars in the hospital parking lot until they were texted or called in. Patients discovered that it was no longer necessary to sit in a waiting room to fill out paperwork or to download and print forms in advance, some of which had answers that they've already provided. And I guess the question I have is, why does it take a pandemic to figure out that we should not make patients sit in waiting rooms for extended periods of time, focusing on us in the health systems versus the consumer? And I'm hoping that that can be a lesson learned through this whole environment. We've also learned that patients are worried about their out-of-pocket costs, perhaps more now so than before during these unprecedented times. I saw a news story recently about a 70-year-old patient, very ill with COVID-19 and about to be put on a ventilator, who briefly woke up from his medically induced coma and told his wife, "You got to get me out of here. We can't afford this." After the patient came home and got the bill, his anxiety increased, even though he knew by then that his insurance would cover it. The article quoted him as saying, "I feel guilty about surviving. There's a sense of why me? Why did I deserve all of this?" Looking at the incredible cost of it all definitely adds to the survivor's guilt. Now I get it. I mean, this is an extreme example, and it's an N of one, but is it an N of one? It's not uncommon during the pandemic for people to think that they have COVID to delay coming into the emergency room until they're very sick because they have no idea how much it would cost them and no way to find out. Even then, when they know it could be a life or death situation. The point being, there's still uncertainty as to some of these revenue cycle processes in their out-of-pocket costs. Then there's the issue of patients needing to figure out what's covered under their benefit plan and what isn't. And you and I know it's a complex industry. It's not straightforward. There should be no charge for patients for COVID-19 testing for the CARES Act and the Family's First Coronavirus Response Act. And that includes antibody testing. But it took a month or so after the legislation was implemented to get the clarification that antibody testing was covered. Another example of fine print was the situation where a patient receives a flu test or a strep test in one visit prior to getting a COVID test at the subsequent visit, which was common practice when the tests were scarce, in which case the full cost sharing for the other tests would apply. The situation with the big bill for antibody testing shown in this slide was different. A physician who worked for a freestanding emergency room chain got an antibody test from one of the ERs in the chain, and his insurance company paid the full amount, but the physician was so dismayed by how much the ER charged that he quit his job. Again, maybe an extreme example, but does that reflect what's going on in a larger scale? and yet gets unspoken. Imagine how the public reacts to stories like this when they read them. It would make a lot of people reluctant to risk incurring those kinds of charges. What if their insurance didn't pay? Is the test really free? Can they trust that it is? When so much happens right now after the fact, and always has, has for many many years. Patients are getting mixed messages, even now after all these months. And again, question I would ask you to think about is, do you really know what your patients think about your processes? Do you know what they really think? Because I think that would point you in a couple different directions. So here's the deal. I've just been talking about some situations that are very specific to COVID-19, but I've alluded to the fact that the reality is that none of these issues are new. The pandemic is like a lot of things, it's just accelerated or accentuated them. COVID-19 is not the only life-threatening illness where patients have major stress about how much they will be expected to pay for their medical care. And sometimes they don't even know. Patients undergoing cancer treatments deal with that kind of an issue all the time. And likewise, the fine print has long been an issue for healthcare consumers. Exceptions, restrictions, conditions, it's hard to get clear, straightforward answers. For example, screening mammograms and colonoscopies are covered with no cost sharing. Diagnostic ones are not. Many patients don't know there's a difference. Of course, and if they find complications, then it falls in different categories. Price transparency is hard to come by, is the bottom line, and we can cite all kinds of different examples. COVID-19 will accelerate the dissatisfaction with our opaque pricing environment in this industry. So, given that the pandemic has accelerated consumerism issues, what can we do as finance leaders to move forward? Well, the first thing, and maybe the most important thing, is to accept that price transparency is a reasonable expectation for consumers to have, and we need to embrace it. In my experience in talking with people in the field, we're not there yet. And research corroborates that. In a study HFMA recently conducted with hospitals and health systems, only 12% of the 151 organizations surveyed described themselves as very prepared for price transparency. And additionally, more than 9 in 10 perceived risks to doing that transparency. Those risks are probably with the prices themselves, and we'll talk about that in a moment. In today's environment, not only because of COVID, but also because of other longstanding trends, the transparency bar is going to keep being raised. The CMS regulations requiring disclosure of payer-specific negotiated rates is just the latest example of that, latest development. It's time to get your organization's price information ready for that level of transparency, and that may mean reassessing your pricing strategy, which I wrote about in my column in the October issue of HFM. A term I like to use is a price hydraulic. You might look at your prices compared to other organizations, and some might need to go up, some might need to go down. It's like a hydraulic, all in reacting to market forces or the marketplace. It's just like what other consumer-facing retailers do every day. We're just not used to it in healthcare. Going forward, being proactive about, be proactive about increasing transparency. Expectations of transparency are only going to go up, they're not going to go down. And the reality is that consumers will expect fewer hassles. They want to be able to do things with their phones. Consider routinizing business practices that were developed for safety purposes during the pandemic, such as the registration process I talked about, making that stick going forward. Look to other consumer sectors for inspiration. There's many industries that have been consumer facing for a long time, and they know the space and how to navigate it. Switching gears for a minute from consumerism to reducing the total cost of care. Some of you may have heard me talk in recent years about chronic conditions as a major driver of healthcare spending. And it's common knowledge that people with chronic conditions like hypertension, diabetes, asthma, who get COVID-19 are at risk for having more severe cases or even dying from the disease. Beyond COVID-19, the term acute on chronic is used to describe situations where someone with a chronic condition, such as COPD, also develops an acute condition such as pneumonia. As you might expect, the chronic underlying condition affects the course and outcome of the acute condition. So looking at the big picture, it's another way to look that the pandemic is drawing attention to the need to better organize management of our chronic conditions. You also may have heard me talk before about social determinants of health, which include food insecurity. Access to nutritious food is linked to lower rates of chronic conditions, such as type 2 diabetes. And as we've just discovered, lower rates of chronic conditions are linked to better outcomes of COVID-19. That's part of the reason for the food is medicine in COVID-19 tagline you see here, which is associated with Mass Health, the Medicaid program in Massachusetts. Mass Health created one of the first programs to allow health systems to partner with social service organizations and provide nutritional interventions for their consumers or for their members. As value-based payments take hold, which will continue to spread, in my opinion, health systems will play a more active role in addressing social determinants like food insecurity. Now, from an overall policy perspective, is it fair to assign all social health issues onto the backs of providers? No, that's not what I'm saying. But will we make cost-benefit decisions like providing air conditioners or meals to keep patients healthy and out of the ED in a shared risk environment? And I think the answer is yes, because it's happening today. So I've thrown a lot at you. So maybe we should talk about where do you start. I've given you, again, food for thought. If you understand it, but it feels too overwhelming, start with the consumerism maturity model. That's it's the item on the right-hand side of the slide. It will show you where the deficiencies are and may help you focus your efforts. For guidance on all kinds of consumerism issues, please check our healthcare dollars and cents section of our website. It's got all kinds of best practices and other resources at the website there, hfma.org/dollars. Now, in closing, it was Winston Churchill that said, "Never let a good crisis go to waste." And now, while he was referring to a very different kind of war than what we have, the battle that we're facing, but it still rings true. In your roles as finance leaders, you've accomplished a lot, and you've learned a lot as you've navigated through this crazy crisis. That hard-won experience will make the months ahead a little bit easier. When we finally get through to the other side of the pandemic, I hope you'll remember both what you've learned and the challenges that were spotlighted by the pandemic that have yet to be solved. And there's more than I've addressed even in this revenue cycle side. There's a lot about 2020 that we'll be glad to put behind us, but there are also some lessons that we're learning and keeping in front of us. So thank you again for allowing me to speak. Again, I miss you all. I miss seeing your faces. I miss seeing you at receptions, and I miss, just like all of you. But like I said in the beginning, next best thing is to do it this way. And so I just appreciate the ability to come address you today. So have a great conference, and I promise, we will be there next year.